Hello, everyone. Welcome back. Here we are at chapter 23, part 2. So we did the anatomy, kind of understood where air was going, how air flowed through the body, things like that. Now we're going to look at the physiology. And to really set up the physiology, we want to make sure we understand a couple of things here. And we want to talk about two different kinds of respiration. To understand gas exchange, we have to first understand that we have a process called breathing, which is external respiration. This is just getting air to the lungs and air out of the lungs. We want to involve in exchanging oxygen and CO2 with our environment, breathing. Now, internal respiration, another name for this is aerobic metabolism. This is cellular respiration. What I wanted to remind you guys of, if you go back and remember from A&P1, we should remember from A&P1 that if you had consumed C6, H12O6, this was glucose or any of its isomers, and we consume that and we breathe in 6 oxygens, 6 O2s here, then what our body will do is in our mitochondria or associated to it, there will be some chemical reactions. We talk about glycolysis, citric acid cycle, oxidative phosphorylation, and these 3 chemical reactions occur in conjunction with the mitochondria or in the mitochondria. So we can see that you will make 6 carbon dioxide, 6 CO2 molecules, 6 water molecules, and somewhere around 36 to 38 ATPs. Okay, 36 to 38 molecules of ATP. And right there, this is what it's all about, is we need oxygen to make ATP, to make sufficient quantities of ATP. If you had me for MP1, then you may remember me talking about glycolysis was anaerobic, which means it occurred without oxygen and only made 2 ATP molecules net. Well, the same thing goes here with us, is that we need oxygen to make ATP. So the uptake of oxygen and production of CO2 occurs from the biochemistry of the cells. And oxygen is needed, and CO2 was the waste product that we gave from that. So that was some important things we talked about in AP1. So the deal here is for us to understand that the gases that are needed for internal respiration, oxygen, the gas that's needed and the gas that is made as a waste is removed by external respiration. We need to do external respiration because we do internal respiration. And we are able to do internal respiration because we do external respiration. One happens because of the other. They drive each other. Okay. Now, any gas exchange process really occurs 3 things. For us to do the processes of external respiration, we need 3 events. We need pulmonary ventilation, and that's breathing. So right now during COVID-19, one of the main things you do is you can put a patient who is suffering from pulmonary issues, is put them on a ventilator to help them breathe, assist in their breathing. This is one of the primary palliative care things, is to put them on a ventilator. So this is why we want to flatten the curve. There's not that many ventilators to go around for everyone if everybody has it and they're suffering from ARDS, acute respiratory distress syndrome. You would need to be put on a ventilator. So that's what's going on there. Now, then we have to go across membranes and capillaries. Gases have to diffuse across the alveolar membranes into the capillaries. And then once it's in the blood, but also gas diffusion has to occur between the capillaries and cell membranes. So we have to have that. But we also have to diffuse from the lungs to the tissues, tissues to the lungs. We have that diffusion, but we have to get the blood from the tissues to the lungs and the lungs to the tissues. We have to get that blood there. The oxygen that's in that blood, we have to transport gases. So you got to breathe, you got to diffuse gases, and we've got to transport those gases through the blood and get those and transport it from the alveolar capillaries to the tissues and back to the tissues to the alveolar capillaries. We have to be able to move the gases through the blood. So we're going to discuss each one of these as kind of separate things. So what I want to do is start off with gas exchange. Now, there's a few things that gas exchange depends on. Pressure of gases. This could be everything from the current atmospheric pressure where you live, your elevation, things like that. Temperatures, a variety of things. Diffusion of the molecules between a gas and a liquid, because gas exchange, to be able to get from the alveolar air into liquid blood, there's going to be the diffusion of those molecules, and that's going to be things like how easy that's going to happen. Depends on a few things. Maybe we talk about the type 2 pneumocytes and how that might affect efficiency of gas exchange, reducing surface tension of water. Now, also, we have lung volumes. Now, for example, if somebody's suffering from emphysema, pneumonia, maybe caused by COVID-19, then this might be going to reduce the amount of lung volume, the surface area of the lungs, and also the solubility of gases to those cells. So how effective is that? If they are very lipid soluble, they go through cell membranes very easy. If they're a little less, they go through a little less easy. If they're not lipid soluble much at all, just a little bit, then it's even harder. And if they're not lipid soluble, they're just not going to get through. And then there's things we can do to aid that. We're going to see how these three things can come together to aid and make it more efficient. Now, pulmonary ventilation, that's just physical movement of moving air in and out of your lungs. And this provides for the amount of air that can get into the alveoli. So remember we talked about the alveolar ducts, alveolar sacs, individual alveoli. If you don't get gases into the alveoli themselves, they're not going to be able to be available for gas exchange. Then there is the atmospheric pressure that we got to talk about, which has a lot of importance. I'm going to mention, do not memorize this value. It's just I'm going to talk about it. It is around 760 millimeters of mercury on average. I do not make you memorize this value because the weight of air is different depending on your elevation. If you guys are at sea level or if you are up on Mount Everest and everywhere in between, you're down in Death Valley below sea level, it will be different. But that's the point. I just want to make that atmospheric pressure is around 760 millimeters of mercury. And many of you, when you guys go on to programs, they're going to use that value as a standard. So that 760 millimeters of mercury, it will be a standard you'll use, but do not memorize it. Okay. I had to memorize it once upon a time, but don't memorize it. Okay. So as we go to look at this, we want to understand that there are pressures. We said the very first thing here was pressure of gases. So we got to understand pressure volume relationship. Now, what I kind of want to do here is set this up in something you may be familiar with, pressure and gases, and that would be the pressures in a car tire. Let's say you have a tire on your car and there's a certain amount of air in that car tire. Your car tires have so many molecules of air in it, and let's just say each of these are supposed to be a dot, but of course, I got a little overzealous and made some of them lines. But every little blue spot is going to be a molecule of air in here, something that is in the air, nitrogen, oxygen, carbon dioxide, something that's in the air is a mixture of different gases. Okay, now, if you are driving along and this car tire here has all the amount of air it's supposed to have properly inflated, then the forces at air, and I'm going to come in and I'm going to use red, and I am going to draw some arrows pointing out that it is exerting an air pressure that is pretty high on the wall of the tire, is pushing outwards, keeping the tire properly inflated. Okay, so what we are beginning to see here is the amount of air inside this tire is, if it's at appropriate levels, you have an inflated tire. Now, let's say we're driving along and somebody drives across, and let's pick dark slate gray here. You're driving along and you run over a nail. When you run over that nail, what is going to begin to happen is some of this gas that was in here is going to begin to leak. And as that leaks out, you're going to start to lose air pressure as air leaks out. And it's just going to start to leak out. And so the pressure of this tire starts to diminish. And you're going to have less pressure in the car tire. Okay? It's just not going to have, oops, I did not mean to hit that. It's just not going to have as much as we wanted. So it's going to lose pressure and it's going to deflate. So I just want to make that point about air pressures. Now, there's a variety of other things you may have noticed that may affect the air pressure of that car tire. Maybe if you guys go out on a very cold morning, the amount of air in the tire seems to be low. The pressure tends to be low. And there's a variety of other things. So I just want to set the stage here is there's a variety of factors that influence the pressure of gases. Now, on this one, we're going to talk specifically about the volume of the container that the gas is in, but the amount of gas stays the same. So in my analogy with my car tire, that was where the tire's volume stayed the same and the amount of gas changed and the pressure reduced. We ran over the nail, sorry. Well, in this case, we're going to get different tires, but we're going to keep the same amount of gas. Now, probably a better way, an easier way to imagine this is, let's say that each dot here represents a student in our class, and the square represented the classroom that we were sitting in before we got put online. And we were in there, I was in there teaching, and we're all used to this seating arrangement we have where you guys kind of got to sit around according to your personal space. And this is, you were used to it. And then all of a sudden we hear a knock on the door, and here comes in Dean Haichu knocking on our door, says, Mr. Leffert, I'm sorry, but this room, we need this room for something else. We're going to have to move you guys down the hall, and you're going to have class in the supply closet. You're like, well, this is just not going to be good. We're not going to like this. I don't enjoy this. We get moved in there. Now we're all just bunched up together. Your elbow is beating against somebody else's elbow. I mean, it's just like we're just packed in there like sardines. And now we're so packed in that every time you even move, you bump into somebody. And now you're about to lose it. You're about to wig out. You're under so much pressure. Every time you even so much as move, somebody's there. You bump into them. They bump into you and they move. And it's like you just try to move, and it's just crazy. You can't, there's no space. You're packed in so tight. You're about to snap. And we're like, we get out of there. Finally, when we leave, you're like, no more, no more, no more. We're not doing this. So then I go to Dean Haichu and I said, we can't do this. My students about lost it. We are packed in like sardines. And he goes and gets us the RCPA. And that's a very big building. And now we're out there spread out nice, where each one of you guys almost could have their own row. And we could spread out. You could put your feet up. You could lay back. You could literally lay back into 3 or 4 seats. And you're just laid back, listen to me. You are so chill in there. It is so low pressure. You got so much room. You're like, man, I'm spread out nice. You're not bumping into anyone. So what we see here is we have our classroom here. We went to a very small space and we are packed in tight. We decrease the volume of the classroom. Well, because of this, there is more collisions with the surfaces of the container and everything around you. That pressure goes up. Here, we got spread out. There is less collisions with the surface, so pressure drops because we are in a bigger space. Now, just remember, way back, we talked about thermal energy and that all molecules are always in motion. And because all molecules are always in motion, they are moving around, and when they move around, they may collide with each other and have chemical reactions, or they may collide with the surface of the container. When they collide with the surface of the container, they produce what is called the pressure in that container. Now, when they exert a pressure on that container because they're moving and getting forced closer together, when volume of a container decreases, the pressure goes up. There will be an inverse relationship, okay? Very important that we understand that if we have a box here, and I'm just going to try to help us understand it. If we had a box right here or a container, and let's say I had a piston on it, and we had some molecules inside of here, then we were to go take the same box, the same exact box, except this time I am going to push the piston down. So let's say we have equivalent boxes here. You can tell I don't like drawing too much with a mouse, but this is working for me as best as possible. We pack these in tighter. See, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We pack it in tighter. So what you're going to see is if we have more volume, we have lower pressure. And if we have less volume, we have increased pressure. If volume is ever reduced, pressure goes up. Inverse relationship, okay? And we must understand that. Okay, so now that we understand that, it's going to be easier for us to understand how the lungs work. So pulmonary ventilation is us moving air in and out of the lungs. And gases are kind of like students. Remember, blood is like students in the heart. Well, gases are like students. And why are gases like students? Remember, if you walked in on the first day of class and the professor says, look to your left, look to your right, none of those people will be here after the first exam. I'm the roundup. And you're like, I'm leaving. This person's crazy. They just want to wipe me out. I'm leaving. I'm gone. Well, that would be that you would leave from high pressure to low pressure. So gases always flow from areas of high pressure to low pressure, just like college students. Now, to do breathing, we need to inhale and we exhale. We call that a respiratory cycle. 1 inhale, 1 exhale. Breathe in, breathe out. Okay. Now, how do we do this? Pulmonary ventilation is going to cause changes to the chest. Volume of thoracic cavity will change. And with that, changes in pressure. We can expand the rib cage. Or we can contract the rib cage. We can expand the diaphragm, contract the diaphragm. Okay, things like that. Now, contraction of intercostal muscles. Remember the intercostal muscles, internal, external intercostals between the ribs and the diaphragm, are the two most important respiratory muscles. Now, in this, if we contract the diaphragm, which means the diaphragm is being pulled downwards here, being pulled downwards, contraction of the diaphragm, and we are contracting the intercostal muscles, expanding the ribs, pulling the diaphragm down, you will increase the volume of the lungs. Now, how does this work? Well, the visceral pleura is on the lung surface. The parietal pleura is fused to the inside of the ribs and to the diaphragm. Remember we talked about hydrogen bonds. And we talked about the transudate or serous fluids in A&P1. Well, because there are serous fluids in the pleural cavity on the visceral pleura and the parietal pleura, when the ribs and the diaphragm move, they are fused through hydrogen bonding to the visceral pleura, and that will expand the ribs, expand the lungs rather. And when we expand the lungs, when we increase the volume of the chest, the lungs also increase in their volume, which lowers their pressure. And it lowers it below atmospheric pressure, and the gases come in. And it's basically just lowering the pressure so that the atmospheric pressure is great enough, pushing it down inwards. Relaxation of intercostal muscles, it's going to cause a contraction. Diaphragms move inward. I mean, your rib cage moves inward. Diaphragm will move up. We relax the diaphragm. It moves upwards. As it moves upwards, you're going to see the chest get smaller. Thoracic cavity decreases in volume. And when volume decreases, the pressure goes up. And it goes up greater than atmospheric pressure, and it pushes the air outside. Okay? So, this is why, now most of the time, for most exhalations, it's passive. It just let go of it. But you can forcefully do this by doing that, okay? So, what we're going to do is to do this, and now I will want you guys, and I will ask you on an examination how we breathe in or breathe out. It's important how we normally do this. Now, a machine can go in and do this for us, but the human body does this normally. For people who may have paralysis of the nerves that control diaphragm and intercostals, or patients with pneumonia, things like that. See, you may deal with patients who have diaphragmatic paralysis, like their phrenic nerve has been damaged, and they are at risk for pneumonia because they won't be able to forcefully cough, and they'll have a risk of pneumonia. Okay, so as you see this, remember, your rib cage expands and diaphragm contracts to breathe in. Rib cage contracts inwards, relaxes. Diaphragm moves up to breathe out. And this creates this inverse pressure-volume relationship. When the volume gets bigger, pressure goes down. When volume gets smaller, pressure goes up. Okay? Now, when I breathe of a single respiratory cycle, there is called a tidal volume. Now, this is a breathe in and out in a single respiratory cycle, a normal respiratory cycle. I want to add more to that later. I will talk about this more in detail as we go here and go here to resting tidal volume specifically. But a tidal volume is the amount of air. It's usually around 500 mils. I can tell you that the entrance exam for Northeast State Nursing likes to ask that number. So they've asked that in the past. They want to know 500 mils. But that's how much we move in and out. Now, remember, it is the diaphragm and the intercostals that do most of this. There are other muscles like the sternocleidomastoid, the scalenes, pectoralis minor, things like that, that also get in, even your serratus anterior. This is why a lot of times when you're dealing with people who have breathing difficulties like COPD, you will see them lean over and start to breathe in deep, and they'll lean. They're getting these other muscles involved in it. That's what they're trying to do. Now, muscles tend to relax because of the tighten. Muscles have an elastic rebound, and it returns your lungs and the alveoli back to the original shape, original volume, original pressures. Okay. Muscles are very elastic recoil. Okay. So it's very passive, usually to relax, though it can be active, like when blowing out your birthday candles. All right, now pulmonary ventilation. If we look at this, our body is always looking at oxygen demand. So if I start to run and my muscles start to burn oxygen, start to consume oxygen, making ATP, it's consuming the organic compounds, it's consuming oxygen through aerobic metabolism, making ATP. I'm needing more. Your body says I need more oxygen. So it's two things you're going to do. Increase respiratory rate, breathe faster, or increase the tidal volume. Increase the volume of air, move with each breath. So that means breathe faster and breathe deeper. So normally I breathe between 12 to 18 breaths per minute. And normally in each minute, with each breath anyway, in a minute rather, I move 500 mils in that minute. So in those 12 to 18 breaths, I'm moving on average 500 mils. Now this might be changed and altered throughout physical activity. And you can increase that, not resting tidal volume, but you will. This is why when people have acidosis, they're panting, okay? We'll talk about that center of the brain momentarily. Actually, one of the last things we talk about. Now, you can use what's called respiratory minute volume and alveolar ventilation. These are important things when you're dealing with respiratory patients. This should say respiratory, not repertory. And respiratory. There we go, respiratory. That is my fault for not catching that typo. I always tend to miss things like that when I'm going through edits. There we go. So, all right. Now, some of these volumes we're going to talk about, you'll need to calculate those when you're setting ventilators, things like that. So right now, that's a big deal, ventilators. Now, your typical tidal volume, as I said, is around 500 mils. Now, only of that 500, only about 350 mils of that actually get to the alveoli. About 150 mils are going to be like in the alveolar ducts. Okay, they're just like stuck out there somewhere. This should have said in the amount of air in like the alveolar ducts or other respiratory places. The amount of air in the ducts. And other spaces in the airway. And that's my fault. What I'm going to do is just kind of edit that out right now. It's my fault for not catching it. I was wanting to talk about that. That's where it often is alveolar ducts, things like that. Now, the anatomic dead space. So basically, that 350 mils is your alveolar ventilation. That is the amount of air that got there for every minute that you breathe in. Now, that could be increased through asthma, anaphylaxis, things like that might increase that dead air space. But it's always there. And this is why alveoli tend to have higher concentrations of carbon dioxide, because the dead air, anatomic dead space air in the dead space, tends to mix. Okay. and you will have a little bit of CO2 left. So it has extra CO2 in it compared to the atmospheric oxygen, atmospheric air you breathe. Okay. All right. Now, alveolar ventilation rate is basically you take your tidal volume and your respiratory rate and you multiply them together. These are not something I am going to have you calculate. But what I want you guys to know, if respiratory rate stays the same, and I need to be able to increase the air getting to my alveoli, I must increase tidal volume. So if I can only breathe so fast, I've got to breathe deeper to increase alveolar ventilation rate. If I'm going to only breathe so much air for some reason, if I have a limit on how much air I can breathe, we must increase the respiratory rate. Now, you may have a patient who has COPD, emphysema, asthma, ARDS, acute respiratory distress syndrome, caused by COVID-19, for example. Trying to make this as applicable to what's going on now. Lung volumes, though, this is going to be a big thing. I have you calculate them, and I will give you multiple problems, probably 3 of them, to calculate being given data from a patient's spirometry results. Okay? Now, our goal here is to understand that we have volumes and we have capacities. Volumes are measured, capacities are calculated. So volumes are measured, capacities are calculated. To help you guys understand them, I do a drawing of this. And what we're going to do, and sorry if you can hear my dogs are barking, Molly especially, our newest dog, she's always like, so I'm going to try to make this, let's see here. I'm trying to make this thing here draw a square. Okay, I don't know if it will. I'll have to just draw the box myself. It's annoying as can be. Sometimes using this thing, I want it to do certain things, but I'm glad I have it because we're going to draw a rectangle. Leave some space on the right. Leave some up. I'm going to need to leave a little bit more space myself. Because I know what's going to happen. I tend to paint myself in a corner when I don't frequently use something like this. I don't do this on the when I'm drawing at home, or drawing on the board in class. And we're going to draw something that looks like this. We're going to draw a rectangle with a bar there and a bar here. Okay. And these should be straight lines. I can draw them relatively straight when I'm doing this with a marker, not with a mouse. Okay, and then I'm going to snag myself. I'm going to use green. I'm going to use a nice dark green so you can see it well. And what I'm going to do is I am going to be drawing a graph of a patient being instructed to breathe in a spirometer. That is a device used to measure lung volumes. Okay, using a clinical test. So first off, I'm going to instruct this patient, take a normal breath. This is how I'm drawing it. This isn't how you will do it, but I'm going to draw it this way. So I say, patient, take a normal breath. And they just take their normal breath in, normal breath out, and stop. Now let's say take a normal breath in, and when they breathe in, hold it. Now tell them to make a maximum exhalation. Now tell them to take the deepest breath they can and breathe normal. Okay, so this is what we've graphed out. We have them take a normal breath, another normal breath, exhale all you can. Normal breath in. Now just exhale and start breathing normally. Okay, so we were able to get that. This is somewhat like what you will do, but not exactly. Okay, so let's start with the volumes of of air that we are calculating here. Okay, so red equals volumes. These are volumes. Okay, so this is our resting tidal volume, V sub T. V sub T, tidal volume, is the amount of air moved in a normal, quiet respiratory cycle. And we call it this because it ebbs and flows like the tides. Now, here we have, so this is the amount of air you normally move. But there is still air in the lungs that could be moved, evident here. I can't exhale. I couldn't exhale anymore. Okay, that was called the expiratory, expire, breathe out, reserve because it stood in reserve, volume because I measured it. Our next volume is residual volume. Now, residual volume has a secondary component, but I'm going to write RV here. And then in that, I'm going to draw a dotted line. And under that, I'm going to write MV for minimal volume. Now, RV, residual volume, there is air in that, but it cannot be moved under normal conditions. You would have to write in here this amount roughly where you get down to the minimal volume. Minimal volume, if your lungs collapse, that's still what's in there. Basically, guys, if I laid you down on the floor and I got on top of a desk and I jumped on your chest, there would still be air in your lungs. And that residual volume, even if I did that, the minimal volume is still going to be there probably. About the only way we're going to get that out of there is to run you over the steamroller and squeeze that air out like toothpaste, okay? It's going to be there. But if your lung collapses, you suffer pneumothorax, you are going to lose part of that residual volume and get down to the minimal volume. Now what we want to do is, so volumes are measured. Let's use blue to discuss capacities of that. So before we get into that, let's look at our notes here and remind ourselves that resting tidal volume is the amount of air you move in and out of the lungs in a normal respiratory cycle. Expiratory reserve volume is the amount of air left after a normal exhalation. Residual volume is the amount of air left after maximal exhalation. And a minimal volume, your residual volume, is a component of residual volume, how much air would be left in a collapsed lung. Then the inspiratory reserve volume is space left after normal inspiration. Now, the volumes here are not to be required to be memorized, okay? I'm not going to ask you, but I'm giving you what's normal according to our book. Okay, so now let's look at capacities. The capacities are calculated by adding up the volumes. Now, you could try to memorize these, yes, but I'm going to tell you it's going to be easier to do what I'm doing here. Now, let's describe first off the inspiratory capacity is the amount of air you can draw into your lungs after you completed a quiet respiratory cycle. It's how much air I can get after tidal volume, V sub T. So that means it must include the V sub T. But it also is our IRV. And look what Mr. Left forgot to write in here. IRV. Sorry. I almost forgot to write inspiratory reserve volume. I almost forgot that volume, didn't I? When I was talking, inspiratory reserve volume is after normal inspiration. There's still more you can breathe in. I forgot about that. So if I take a normal breath in, then breathe more. Okay. Now, I'm sorry I almost forgot to do that. So I'm glad I caught that. It could be easy when you're out of pocket. So if I go to this line here and this line here, and I box that up, we are looking and calculating, remember, a volume called the inspiratory capacity. This is all of the air I can maximally breathe in. This includes my tidal volume, a normal inhale, and then what I can breathe on top of that, inspiratory capacity. Now, we got that one. This is an easier way to learn these than memorizing the equations. You will be able to see this in your head. Now, the next one is functional residual capacity, the amount of air remaining in your lungs after you've completed a quiet respiratory cycle. So, after tidal volume, so that means if it's after tidal volume here, you are now in this case it's the amount of air left that you still could breathe out. So in this case, functionally, it's what's left over. That's ERV plus RV. ERV plus RV is functional residual capacity. It's after I've exhaled a normal exhalation, it's the amount of air left, including the amount of air I can move and theoretically could move. So it's all of this, okay? Now what we're going to see is vital capacity. That is all the air that you can move in and out of the lungs. The total volume of air that you possibly can move, the maximum amount of air you can move in or out of your lungs, which means it includes everything here. That the green line that I graphed is vital capacity. That is the air you can breathe in and out. That is all the air you can move in and out of lungs. Okay? And then it's obvious that total lung capacity, the total volume of air that your lungs can hold, is total lung capacity. Sorry about the dog. Okay, so that's total lung capacity. It's everything. It's all four main volumes. Minimal volume, remember, is the sub-volume or RV, but it's these four big ones here that we especially are going to be given to calculate something. Now, I do want to make a clinical nugget just for your edifications. Hold on one second. Okay, maybe she is now done throwing a fit. Okay, so with all these, if you can draw this and be able to visualize this in your head, it is a lot easier than to memorize the actual equation, okay? It is a better way of understanding. And I'm going to say as a student and as an instructor, I had a hard time memorizing these equations. But once I did the drawing and put that together for my students, I know them now. Sorry, every time somebody walks by our house, now that everybody's at home and our dogs go nuts. All right, so with that done, let's start moving on to the next things. So here's a drawing done by our textbook, much like what I was trying to draw, and you can typically see some of these like volumes here, as I was saying, 1,200, things like that. So anyway, as we look at that, here's some sample calculations for you to practice. And I've given 4 of them to give you guys things to practice on. Recommend you do them. There will be some in the chapter review as well. Now, let's look at gas exchange. I got to pause again. Dang. Okay, so gas exchange, now we're going to look at the part where we diffuse things across cell membranes and get it into blood. So the diffusion is all about concentration gradients. Now, a lot of the physical laws, now we talked about a law, and I actually forgot, I just realized I didn't call it Boyle's law. The pressure-volume relationship was Boyle's law. That is what it boils down to, is pressure-volume relationship. Okay. And I forgot to call it that, I believe, in my lecture. So what we want to see now is Dalton's law of partial pressure. Now, let's just make sure the air you breathe is a mixture. We have nitrogen, oxygen, water vapor, carbon dioxide. Now, I want you guys to be thinking when you're on campus, when you guys go to campus or you go out somewhere, let's say ladies in your purse or guys in your gym bag or your backpack, any ladies and gentlemen in the classroom, when you are in when you go to class, you carry a backpack. And in that backpack, there's a variety of things: pens, pencils, paper, notebooks, other little things, all the little things you have, chargers for your devices, your device, um, all kinds of things you might be carrying around there, all sorts of little things. And when you put every little thing that's in your backpack, each of those little things weighs something. Some of those things are bigger and weigh more. Some of those things are smaller and weigh less. And you put those on your backpack, and combined, all of that puts pressure on your on your backpack. That's what partial pressure is. Partial pressure of a gas in a mixture, so that each gas in a mixture, each of those have their own partial pressures to contribute to the pressures of the gas. Well, these are all molecules. Remember, we did molecular mass in A&P1, where we calculated the mass of a molecule based on its molecular formula by adding up the mass of each atom that composes it. Well, if you have a mixture of many molecules, we know that N2 weighs something, we know that O2 weighs something, H2O weighs about something, CO2 weighs something, and we get the partial pressures of each one to create air pressure, okay? So that's partial pressure. So partial pressure is roughly related to air pressure, or roughly related to concentration. That's what I meant to say. Sorry. Okay, so as we get an understanding of that, that gives us Henry's law, is that partial pressures of a gas, when a gas under pressure comes in contact with a liquid, it dissolves to an equilibrium. Now, that depends on temperature, the amount of gas, solubilities of the gas, things like that. At a very given temperature and an amount of gas in that solution so let's say we have one temperature versus another temperature. Here I've got a can of soda. When you put the can under pressure, it dissolves more carbon dioxide. When the pressure is let off, it dissolves less carbon dioxide. But also, if you let that soda get warm, it goes flat. Okay? It is at a particular temperature. So at a particular temperature, the amount of gas in solution is proportional to partial pressure. So one could say that partial pressure and concentration are related, but they're not identical. Okay, they're kind of like they go hand in glove, but they're not identical. And I do want to make a distinct difference about that. It is not a perfect relationship. But when everything, like, when you're at constant pressure, constant temperature, when that all stays constant, then okay, at that concentration of gas, the partial pressure is a uniform thing, okay? It will get to an expected equilibrium for that solution at that temperature, at that concentration. Okay. Now, gas content is also driven by partial pressures and temperatures, but also the solubility of gas in a liquid. Now, in body fluids, CO2 is very soluble in your body fluids. It is extremely soluble in body fluids, easy to get a fair amount in there because of the way the chemistry involved, it will become bicarbonate and be able to dissolve fairly easy. That's why. O2 is a little less soluble, and N2, nitrogen, is not very soluble at all. And in fact, if you were to go in and breathe in oxygen from an air tank, which actually has a fair amount of nitrogen in it, but nitrogen is not very soluble in gas, in liquids, in blood, then what's going to happen is when you come up from diving in the ocean, that nitrogen, who is now at a new pressure, will come out of solution and form nitrogen bubbles, causing nitrogen narcosis or the bends. And this is why these things happen physiologically. So the gases and how they diffuse across respiratory membrane is going to be aided by, because oxygen is less soluble in the blood than CO2 is, you're going to need a very high partial pressure of oxygen to help get it across. It's kind of like, I'm not as easy to cross that, but I've got extra help. It's like if your O2 is kind of like me trying to get into a hip club in town, and the partial pressure, high partial pressures behind me would be like if I brought some good-looking women with me. Well, those good-looking women with me, that's increasing my partial pressure. It's going to make it likely I get in. It's easier to get in these places for a dude like me if I got some good-looking women with me, okay? Or I got a lot of money behind me and I can bribe the bouncer, okay? That's how oxygen is aided by. O2 needs a higher partial pressure to aid its diffusion. CO2 doesn't need as much partial pressure because it's far more soluble and diffuses across the cell as well, not only in fluids, but also across cell membranes because of its chemistry. We will understand this better as we go, okay? I'll talk about that a little bit. Now, so to increase efficiency, you need to have differences in partial pressures. Gases will move from high partial pressure to low partial pressure. We're going to talk about that. We have very short exchange distances because the alveolar epithelium and the endothelium of the capillary cell share the same basement membrane. And O2 and CO2 are relatively lipid soluble. They're pretty lipid soluble things, so they'll go through. CO2 is more soluble, and it's actually quite soluble because of the chemistry of it. When it gets into plasma, it's going to react and change and be converted, and there's some cool chemistry that happens. The lungs have a large surface area, and also, remember we talked about the respiratory pump? Then blood flow and airflow are coordinated, so that as blood is coming in, coordinate with airflow. And that's important too, that we always have that coordination. Now, what I'm going to do is begin to draw something out. And this is a big drawing, and I will ask these on the test. You are required to memorize the different concentrations of gases. So if you got this, now of course you can rewind and pause, and I would draw this out. If I draw something, you probably really want to draw it multiple times. These volumes and capacities are very important when you get into healthcare. You are going to use those to calculate and actually set the ventilators on a patient. Now, what I'm going to do, actually I'm going to start with black, and I'm going to go over here and I'm going to draw body cells. Here we have tissues. These are your body's tissues. This can be any kind of tissue. These are body's tissues. And over here, I'm going to draw an alveolus. Okay, now how do we get this to here? Well, we need bloodstream. And since we need bloodstream, let's start off by see, that was supposed to turn red. I remember distinctively clicking red, but it did not. I don't want to use the light red. There we go. Okay, so let's get a blood vessel here. Okay, so there's our bloodstream. Okay, so now what I want to do is I'm going to go in and I'm going to write air here, okay? And this is the alveoli. Alveoli here, these are the tissues here. Now, let's start off with tissues since we already know tissues are consuming oxygen and producing CO2. And so since they're doing that, we will see the partial pressures of O2 and the partial pressures of CO2. CO2 has a partial pressure about 45 and 40 for oxygen. Okay? So this tells us we're consuming oxygen and producing CO2. Now, let's say in here in the alveoli, we breathe from our air, and I'm not going to, again, I hit red, I know, but, and then I know I clicked on that, at least I thought I did, but who knows anymore. Okay, so I need my pen, I need red, okay, so when I breathe in air, it's going to have a partial pressure of O2 at around 100. Now, the value for this is millimeters of mercury. I'm just not going to write that. And the PCO2 is around 40. Okay, now, so as you can see that, we've got these values in here for the tissues and the alveolus, okay? Now, what we want to do is to understand a few things here. Venous blood and arterial blood. Well, what I'm going to do is I am going to be taking my red arrow here and I'm going to draw directions of blood flow. Now, this means for us, we're going to deal with systemic vessels on this drawing. So right here, what you guys are going to be dealing with is arterial blood. And the partial pressure, PO2, of oxygen, we're going to say it's going to stay at 100. And the partial pressure of carbon dioxide at 40. Now, what is going to happen? As I arrive to the tissues, the partial pressure of oxygen drops by here about 5 millimeters of mercury of pressure. It loses to about 95 millimeters of mercury of pressure, okay? It's going to get down to about 95, and it loses it. I mean, there's cells in the blood, in the plasma, that are going to take oxygen. They're going to consume it. Blood cells might don't really need it. Red blood cells, white blood cells, endothelium, things like that may need it. Platelets may need it. So, and the PCO2, partial pressure of carbon dioxide here, is still at 40. Now, here's where we're going to start our journey here, okay? Now, gases move from high partial pressure to low partial pressure. So this means when oxygen at 95 arrives to the tissues at 40, you're going to take O2 and deliver it to the tissues. And when CO2 here and the tissues at 45 and CO2 in the blood here at 40, you're going to give off CO2. And when that blood leaves here, it is going to have a PO2 of 40 and a PCO2 of 45. just like the tissues, okay, when that blood left. So now what we've got is our venous blood. And one of the questions I will ask is like venous blood versus arterial blood concentrations, and what happens and how the partial pressures at different sides of this drawing affect things. So venous blood has a PO2 of 40 and a PCO2 of around 45. Now, is this always? No, but this is normal. And this blood arrives here to the capillaries in the alveoli. And again, let's write that out. PO2 is 40. PCO2 is 45. Let's write that out. Now, if we look at this, remember, CO2 here, CO2 here. So what's going to happen? You're going to give off the CO2 to the alveolus and breathe that out to the air, okay? And then if we look at the oxygen levels, 140, and you're going to deliver the oxygen to the blood. And you're going to create a blood here that is a partial pressure of oxygen at 100. Oh, let me rewrite that so it's clear. Of 100 and a partial pressure of CO2 that is 40, just like the alveolus. So the blood leaving the alveoli matches the gases here. The blood leaving the tissues matches the gases here. So now you know how we produce arterial blood. Now you know how we produce venous blood and how we oxygenate it. So I do recommend that you draw this. I'm going to ask how the partial pressures in the tissues affect gas exchange. How they do the partial pressures at the alveoli and alveolar capillaries affect the tissues. Okay, movement of gases. Okay, partial pressures and how they affect that. I'm going to ask you what venous blood or arterial blood's partial pressures are, and things like that. So you can expect a handful of questions, about 3 questions at minimum here, because it is a very big topic. Okay, so that is actually your 2 hardest things for this chapter done. So you can see this, and you can see these, and I've color-coded them on the slides and drawn them out to teach it. And I do, by the way, have a YouTube video where I've done just this. So if you're like, well, I really would like to just see that and not see anything else, and if you just want to go to my YouTube channel to watch it, all you got to do, again, myelination, all one word. And if you guys go to the channel, you must search myelination, all one word. You'll see that I'm actually been putting lectures up. But all you have to do is go to my respiratory playlist, and you will see this guy here, gas exchange, where I did some extra stuff and extra drawings and explained all this. I used a different color coding system on this, but please watch it. It's going to help you guys out a lot to see that if you just want to watch that. Okay, so lastly, we got to talk about oxygen transport, and then we're going to talk about respiratory control. Now, the 2 important things is most of your O2 is transported on hemoglobin, but some is dissolved in blood, just gets dissolved. Not much is dissolved in plasma because our body doesn't produce significant pressures to do so. Most is bound to hemoglobin. Now remember, On hemoglobin, now I'm going to erase this, so if you are ready to, you can always go back and rewatch it and pause it and draw it. Pause at any time, but I'm doing longer videos instead of shorter videos because students have a hard time finding everything when I sometimes. So this is the way I'm doing. Okay. Now remember we talked about hemoglobin, and I was like, okay, with hemoglobin, our hemoglobin's here now. If everything's bound together, of course. We have that quaternary protein there, and all bound together. And then what we did was we went in with our green, and remember we drew, I always like to use green for some reason, and it has ferrous iron, not ferric, Fe2 plus plus plus. Again, sorry for Molly. Okay, so we got our Fe plus plus 2 plus Fe2 plus on that, and remember that is where all of these oxygens will bind. But it's O2s. So remember, it is O2. Let's use just for our purposes, the O2 here binds to it in O2. Then we can do that here, O2. Then we can do that here, O2. Then we can do that here, O2. So you can bind it to 4 O2s. Remember that. Now, when we have it bound, it's called oxyhemoglobin. When it doesn't, when it releases it, we start calling it deoxyhemoglobin. And it is reversible. It allows us to be able to drop off and pick up oxygen. Now, hemoglobin is rather cool in the fact that it can let it go and pick it up. Now, CO2, on the other hand, is a little bit more complicated. Now, one of the things we need to make sure we understand here, and in a minute, I'm going to talk about why it happens a little bit. But I want you guys to memorize 70, 23, and 7. Okay, 70, 23, and 7. Now, CO2 is a byproduct of cellular respiration. And when this happens, CO2 reacts with water. And one of the things it does is it forms carbonic acid. And ultimately, carbonic acid is converted to bicarbonate. And that is how we transport is bicarbonate. 70% is bicarbonate. 70% carbonic acid to bicarbonate. And it is actually more accurate to say 70% is transferred as bicarbonate. Okay, then also about 23% binds to hemoglobin. We call that carbaminohemoglobin. It binds to the protein part of hemoglobin, not the heme. And 7% dissolves in plasma because it is more lipid soluble. It is more lipid soluble, okay? Now, there are two ways to control breathing. Voluntary, which means I can hold my breath or I can make myself breathing. I do voluntary. My cerebrum can do voluntary control of involuntary systems. So I can hold my breath, for example, when I go underwater. Or force myself to take a breath knowing that this might be my last chance. Take one for a little bit. And then involuntary controls your intercostals and diaphragm, how much and how fast, how deep. It controls your breathing. Now, to set off the just in a respiration, we have chemoreceptors. Now, they are in your carotid arteries. There is two nerves, the glossopharyngeal and the vagus. Glossopharyngeal is monitoring your, so you have chemoreceptors in carotid arteries, and in your glossopharyngeal, aortic with the vagus. These two nerves, monitor them differently, okay? Now, what do they both do? Well, what they're doing, and this is an incredibly important thing that we understand, we saw this in chapter 21, and this is something very important to understand. If any time we ever decrease oxygen, this means we increase CO2 as well. And when CO2 goes up, we decrease the pH. Or is to say we increased acidity. Okay? We know we did those things. We must know that, okay? That is something we have to understand. The chemoreceptors monitor your blood CO2 levels, and if CO2 goes up, pH goes down, becomes more acidic. The decrease in oxygen, okay? You must know this. And this increases the depth and rate of breathing. Okay, now baroreceptors, their increase in blood pressure. Now, if blood pressure drops down, your respiratory rate goes up because that actually helps increase venous return, thereby increasing stroke volume, increasing blood pressure. When blood pressure goes up, respiratory rate goes down because that's going to help lower venous return, lowering stroke volume, lowering blood pressure, okay? And that's it, really. Now, the three places that control the brain, that control respiratory rate, the respiratory rhythmicity centers in the medulla oblongata, and it's the rate medulla oblongata, medulla oblongata, medulla oblongata. You got to get a rate, got to get a rhythm with it, medulla oblongata. Medulla oblongata. And you got to get that rate, that rhythm, respiratory rhythmicity centers in the medulla oblongata. The apnestic center, apnestic, is in the pons, and it does strong inhalation. I always like to say when mama goes ape on you, she's like, and then she goes off, okay? She's like, she takes that deep breath in, you know you had it because she's just about to go ape crap on you. Apnestic. Pneumataxic center is in the pons as well, and it causes strong exhalation, so it's inhibitory of apnestic. So this means your apnestic center here, or apneuestic center, I apologize, I've got to get the apneuestic center. I've got a typo there. There we go, apneuestic center. I apologize so much for that. And it becomes inhibitory of that. So like if you want to blow out your birthday candles, okay? All right, now these diseases are on the exams, things like COPD, SIDS, emphysema, pulmonary embolism, asthma. I could talk about SARS-CoV-19 or COVID-19, coronavirus disease, 2019. COVID-19, but that is causing, it's by the group of viruses, coronaviruses, that called the SARS outbreak and also called the MERS outbreak. Some things in 2008, 2012, things like that. So guys, that concludes that video. Hope you guys find it helpful. I'm sorry about the typo there. I keep finding these every now and again that's what I get for typing every slide letter by letter. Guys, thank you so much for watching. Have a great day. Stay safe.